Good afternoon, everybody. We're just waiting for Zoom to fill up to let all the participants in. So if you just give us a minute, we'll let all of the people who are attending log in, and then we'll kick off. It's brilliant to see so many folks coming online today to hear Professor Gallagher's talk. Oh, we still have a few coming in. Okay, I can probably click start off anyway and say a few words of introduction and welcome. Firstly, thanks to all of you for joining today online. The Irish Cancer Society is very keen to make sure that we talk about research and about the impact of research and to make it accessible to people. And I suppose one of the small number of advantages of COVID is we've, I suppose, become a little bit more used to this kind of technology. We would have done these talks in different locations previously, physically, obviously in person. A few housekeeping elements, as I say. We're going to record this presentation, so it will be available on playback later on, and Shauna, my colleague, will make that accessible. In addition to thanking you, I want to thank the team who've organized this, especially Shauna and Claire in the background, who've done a lot of work to make this happen. And I will be saying a big word of thanks to Professor Gallagher from UCD in a moment as well. It would be great to get some questions. And if you wouldn't mind, if you look at your screen, down at the bottom of it is a Q&A box, two little kind of call out buttons on it there. If you wouldn't mind putting those questions in as we're going along, that'd be great. And we'll try and get to as many of them as we can. Just if you put them in as we're going along, they won't interrupt the flow, and then we can order them as we're going through. So I'll kick off. October is Breast Cancer Awareness Month, and thankfully we're seeing a lot of awareness about what's going on in breast cancer, a lot of awareness about things that we can do to help mitigate the impact. And I suppose one of the challenges in this space is that breast cancer isn't a single disease. We often think of a concept of a lump and that, but actually breast cancer is a large number of different diseases, and it means different things to different people who are impacted by it. So those can be women as well as men. A small number of men are also impacted by breast cancer. So we thought this would be a great opportunity to have a conversation about breast cancer research, particularly in Ireland. Many of you will be aware that the Cancer Society has been committed to breast cancer research for a long period of time. And previously we had supported a very major initiative bringing together all of the best and the brightest researchers in Ireland around the different topics and challenges of breast cancer research. And this was called Breast Predict. Liam will go through the details in a moment around all of that. So that brings me on to welcoming Professor William Gallagher, or Liam, as he's known to many of us from all the years that we've all been working together. And just to give a little bit of background on Liam, he's a full professor of cancer biology in UCD School of Biomolecular and Biomedical Sciences. He is currently Deputy Director of Precision Oncology Ireland, which is a large-scale strategic research partnership funded by SFI, as well as supported by different academic institutions and 6 Irish cancer research charities, including the Irish Cancer Society. He's co-lead of an emerging virtual institute called the All Ireland Cancer Research Institute, and if we get time at the end, I think he'll mention that. A little bit of his background: he graduated from the Department of Biochemistry in UCD in '93, and subsequently obtained his doctorate, his PhD, from the Cancer Research UK Beatson Laboratories in Glasgow. In '97, he moved to Paris to undertake a Marie Curie individual fellowship, and he returned to Ireland upon receipt of an Enterprise Ireland postdoc funding scheme in 1999, and subsequently also got a Marie Curie return fellowship. From 2013 to 2019, he led our Breast Predict Centre, which he'll talk about in a moment. And that was really the first major initiative of the Irish Cancer Society, €7.5 million of donor money put into that to enable and leverage. And I think you'll see some of the amazing work that came out of that program. And I suppose on a personal level, like all of us, Liam and his family are impacted by cancer, and he's been particularly a vocal advocate for timely access to services and supports, especially in his native Waterford. And I think a lot of people will have seen Liam talking about that as well. And I think that illustrates the excellent science and research, but also the human aspect of us all being involved in trying to raise the bar for everybody. So without further ado, thanks again to everybody, and I'll pass over to Liam, and thanks very much for your time today, Liam, in pulling all this together.
Thanks very much, Rob. First of all, I'm really delighted to give this talk for both professional and personal reasons. So what I was hoping to do in the next 30 minutes is really give you, I suppose, 3 different kind of aspects to breast cancer research. Talk a little bit about the past. I'm going to talk about Breast Predictor Program, which I had the pleasure of directing for 6 years, which was funded by the Irish Cancer Society. And then talk about, I suppose, what came from that program and then what we're hoping to do next. So look, I'll click into the presentation. So just first of all, it's important that I have some disclosures to mention. I have been involved. I am interested on the commercial side, and I suppose getting technologies out there and into the clinical context. And it's important to have kind of, I suppose, industry support in that context. So in terms of breast cancer, in Ireland, we're talking about, in the context of women, potentially 1 in 10 or even increasingly 1 in 9 women will develop cancer during their lifetime. And in relation to men, that's about 1 in 1,000. So again, it does affect both women and men. We see worldwide that the global incidence of breast cancer is increasing. And that's, I suppose, thankfully due to improved screening, but unfortunately also due to lifestyle changes. And that's predicted to increase significantly to 2.6 million by 2035. So, we have this growing problem in terms of breast cancer. So on the positive side, mortality is decreasing due to earlier detection and better treatments. So for example, in the case if you're presented with localized disease where the actual tumor hasn't spread, for example, beyond the primary site, the breast, the prospect of 5-year survival is excellent. Now that may vary depending on the subtype of breast cancer that you may have. Obviously, the challenge really is if the disease is spread beyond the primary site, either to the adjacent lymph nodes or to distant sites. Unfortunately, the survival tends to drop off. Now, this is starting to change with improvements in treatments. So the important thing to acknowledge is that most patients diagnosed with breast cancer now survive. And this really puts forward this concept that it's very important to tailor treatments. We have a lot of treatment options available to us. And the idea behind, I suppose, a lot of what we did within Breast Predict is come up with strategies for really, I suppose, this tailoring of treatment, which is called precision medicine or precision oncology, and importantly, to avoid side effects. The other thing is important is that we understand more about the risk factors which contribute to breast cancer. On the left-hand side are factors which are potentially changeable. For example, we know that obesity is a risk factor, alcohol, lack of exercise, and duration of hormone exposure can have an impact in terms of breast cancer formation. So these are potentially changeable factors. And then we have factors which are unchangeable, genes that you may inherit or mutations that you may inherit from your parents. For example, people will be familiar with the BRCA1 or BRCA2 genes, which confer a very high risk potentially of getting breast and or ovarian cancer. And also, unfortunately, as we age, this actually increases our risk of cancer over time. So as Rob mentioned, we have within breast cancer, it's not just one disease, it's a collection of different subtypes which are defined. For example, when a tissue is excised from a patient, this is assessed in the pathology lab, and generally 3 markers are assessed: ER for the estrogen receptor, PR for the progesterone receptor, and HER2, which is a marker which I'll talk about a bit later on. And the initial treatment options are heavily dictated by the status of those particular markers. For the vast majority of patients, they present with what's called hormone receptor positive disease, either ER and or PR positive. And in that context, patients are generally given hormone therapy. And again, one of the mainstream hormone therapies is tamoxifen or other forms of anti-endocrine therapy, and plus or minus chemotherapy. The other category of breast tumors which are defined are what's called HER2 positive. Approximately 15% of patients are HER2 positive, and Classically, this would have conferred maybe a higher risk of disease relapse, but thankfully, due to the emergence of HER2 targeted therapies, this has really dramatically changed the treatment course of those individuals. Now, there is a challenging subgroup called triple negative, and it has an unfortunate title. In this context, you don't express the estrogen receptor, you don't express the progesterone receptor or HER2. And due to that, these initial kind of more targeted treatment options like endocrine therapy or HER2 targeted therapies were unfortunately not given in that context. And the mainstay until recently has been to give chemotherapy in that context. Now that is starting to change. There's a huge amount of work in that space, and there's been some recent developments, particularly in the context of immunotherapy in that subgroup. So this is a flavor, and as I mentioned, there's a variety of different treatment options out there. And again, chemotherapy is still an important mainstay for treatment in breast cancer, for example, in combination with endocrine therapy, in combination with HER2 targeted therapies, and in other contexts. But again, there's a shift towards, chemotherapy, while useful, it tends to be a bit more non-specific. It tends to target other normal cells in our body, and this leads to side effects. And there's really a shift towards more targeted treatments, which target maybe a specific alteration in cancer. And that, for example, could be, I'll give you a good example of HER2 in a minute, but there are some emerging examples beyond that. For example, there's a well-known biological pathway called CDK4/6 signaling, which now there's a variety of different drugs which are being trialed and now approved in the context of kind of targeting that pathway. And as I mentioned, classically, breast cancer wasn't really thought to be highly responsive to immunotherapy, but there are certain maybe subtypes of breast cancer, particularly, for example, triple negative breast cancer, that may be specifically responsive to immunotherapy. And there's been some recent interesting developments in that context, particularly in the US, with the approval by the FDA of a combination of pembrolizumab plus chemotherapy for early stage breast cancer. So a bit about the past. So this is really a kind of landscape over the last 100 years, I guess, in terms of breast cancer. And really the main thing is that we've learned a huge amount in terms of how breast cancer forms, but also how we can actually now manage breast cancer both surgically and in the context of chemotherapy and other treatments. So I'll just really highlight a couple of those developments. So I did my PhD in a place called the Beatson Laboratories in Glasgow, and it's named after the surgeon George Beatson, who published a very important paper in a big journal called The Lancet over 100 years ago, where he actually performed the first ovarectomy, removal of the ovaries, as a treatment for breast cancer, patients with advanced breast cancer. Now, this has changed towards more targeted drug-based treatment approaches to, I suppose, affect hormone function. And the other kind of key event, which was actually published, the first author of this paper was Maya Cole. I'll have a slide on her in a minute. And she published the first paper on the use of tamoxifen in 1971 in the context of treatment of advanced breast cancer. And this is in patients which were unselected at the time. These were patients which weren't defined by their estrogen receptor status. The other kind of key hero for people internationally, but also has been very, very good to Irish cancer research, is Dennis Lehman. And Dennis Lehman and colleagues, who's based in University of California, Los Angeles, was really provided the first association between overexpression of this HER2 protein in breast cancer, which is acts like a switch or a driving force for breast cancer. And again, he played a pivotal role in the development of therapeutic strategies, particularly Herceptin, drugging or targeting that particular protein. So again, I mentioned Maya Cole. Again, you probably may or may not be familiar with her name, but essentially she's a hero for cancer research in Ireland. She was born in County Cavan. She was the first author. She was a radiologist, and she spent most of her research career, or kind of clinical career, in the UK. And again, she was the first author of the first study of tamoxifen in patients. And again, what was interesting, if you just look at the bottom line here, it said here, the particular advantage of this drug is the low incidence of troublesome side effects. So again, this is the benefit of hormone therapy. It's not saying that there is no side effects, but it potentially, it was one of the first examples of a more targeted form of treatment. So one of the key questions that's emerged over the last number of decades is this concept of, obviously we're detecting breast cancer much earlier. We have hormone therapy as an attractive therapeutic option for hormone receptor positive patients. And the key question is being, do you need chemotherapy on top of that? And again, we know that from various different studies that the vast majority of patients, maybe above 70% of those patients with early stage ER positive disease, actually have a low risk of distant recurrence. They can do perfectly well with surgery plus hormone therapy, and they don't really stand to, there's no requirement for chemotherapy potentially. And now there are potentially a subset of patients which will have a high chance of recurrence. And the other key question is, well, do those patients, are they going to specifically respond to chemotherapy? And one of the kind of first tests that was developed over 20 years ago was the Oncotype DX test, which was one of the first kind of molecular tests which was out there clinically in the context of breast and other cancers. And this was essentially trying to assess that primary breast tumor, look at a small number of genes, and predict whether the patient was going to have a distant metastatic event within maybe a 10-year period. And if there was a low risk of distant recurrence, maybe you could suggest to avoid chemotherapy. And if there was a high risk of distant recurrence, maybe you might suggest to also give chemotherapy. And Irish clinicians and patients had a very pivotal role in the context of the validation of this technology in the largest clinical trial ever performed, called the TAILOR-X trial, which I think had over 11,000 patients worldwide, of which over 700 patients, or close to 700 patients from Ireland, participated in the validation of this assay. The other key marker, which I mentioned, is HER2. And again, this is a picture of various different breast tumors. And when you assess HER2 expression down the microscope, or a pathologist looks at it, it looks essentially at the rim around the breast tumor cells. And if you've got high expression of HER2, it's seen as a kind of brown rim around breast tumor cells. And they classify patients' samples as either being 3+, where you've got a lot of this expression of that protein, all the way to nothing. And again, generally in patients which are 3+ are suggested to get hormone therapy or to HER2 targeted therapy. And if they're 2+, they're sent for another test to confirm whether there's an alteration or not. And what's really amazing about this whole field, again, mainly driven by initial work by Dennis Lane, but also Professor John Crown and other colleagues in Ireland, it's a whole spectrum of different therapeutic options which have emerged now targeting HER2, including very clever approaches now, which recently have shown to have a dramatic impact on metastatic HER2 positive disease, where you actually bring a chemotherapy drug not closer to the tumor cell using a drug conjugate approach. So there's a whole spectrum of different options now really out there in the context of HER2 targeted therapies. So this brings me to Breast Predict, and the original vision for Breast Predict was from Professor John Fitzpatrick, and late John Fitzpatrick, and Professor Fitzpatrick was a noted urologist who became the first head of research at the Irish Cancer Society. And he had a vision, I suppose a dream, of cancer researchers coming together, working collaboratively towards, people from different backgrounds, basic scientists working with clinicians, mathematicians working with people who are working in the laboratory branch. And a call for proposals for the first collaborative cancer research centers came out back when it was at probably early, it was 2011 or 2012. And we put a program together called Breast Predict, which we were successful in terms of getting the award, very significant award at the time of $7.5 million over a 6-year period. And what I was hoping to do is just spend a couple of minutes just talking about what we did in the context of Breast Predict. And again, for me, it was the most important thing I did in my career and have done to date in my career. Had a very big impact, and had a lot of output, and still has a lot of output. So our vision really at the time was to make personalized medicine a reality for breast cancer patients in Ireland. And the concept that Professor Fitzpatrick had was really to combine 3 key elements: essentially clinical element, for example, clinical trials; a translational element. And what I mean by translational science is, someone like me who works maybe at the laboratory bench trying to come up with a discovery or bring it closer to clinical reality, maybe in a clinical trial setting. That's called translational research, which either can go from a bench to bedside, but also you can take an observation from the clinic and bring it back and try to understand it in the laboratory bench. And the other part, which was very important, was look at a population-based level in terms of the whole population within Ireland. And for example, there was key work from Professor Kathleen Bennett and Dr. Ian Barron looking at the impact of prior drug exposures, for example, the impact of statins or aspirins on the diagnosis of both breast cancer, but also the outcome from breast cancer. So again, it was a very significant investment. It funded a team of people working over 6 years on a set number of questions in the context of breast cancer. So we had 19 PIs or principal investigators involved from multiple 6 different academic institutions around Ireland, and also importantly, the clinical trials organization, Cancer Trials Ireland. The funding, the €7.5 million, very significant funding, was unprecedented at the time in an Irish context. This funded a team of researchers, I suppose a gel between those different research groups. It funded, I'll come back to the kind of numbers a bit later, but essentially we had 6 key goals. And again, around those goals, we really want to keep patients at the heart of of our research. We had some specific goals. We want to create a national breast cancer biobank and database. We made very significant progress in that context. And then we had specific research questions, and I'll give you examples of what came out of that. We wanted to again look at the impact of prior medications on breast cancer outcomes, for example, the impact of aspirins and statins. We wanted to understand really, we can see that maybe some patients have an initial response to treatment. It could be HER2 targeted treatment, but unfortunately in a subset of those patients, they may present with a distant recurrence later on. And unfortunately, the initial treatment doesn't work. So we're trying to understand what has changed in that context, and can we actually overcome that change and come up with new treatment approaches. Again, can we come up with new combination strategies and new drugs or therapeutic approaches, but also can we predict upfront who's going to respond or not to treatment? So these were the kind of different broad goals. Again, as I mentioned, we had 6 different academic entities involved, plus Cancer Trials Ireland. It funded a big team of researchers, essentially 13 PhD students. I'm going to give you an example of some of the PhD students, as well as postdoctoral fellows, and also other individuals really to provide support for the research team. These are just some highlights over the 6-year program. And again, the program finished in September 2019, but the kind of impact of breast predictors really will be felt over, is already still being felt and will be felt for the next 5-10 years. As of September 2019, this is what I suppose the current pulse was in terms of the outputs from that program. We had, I suppose, looked at investigating 17 novel therapies, and some of these have reached the clinical trial phase, as well as 7 breast cancer diagnostic tests. We'd published a lot of key papers, and again, papers are very important to actually communicate the results from our research to the international community. We'd also participated and helped in terms of ongoing clinical trials and translational studies in close liaison with Cancer Trials Ireland. And we had actually taken that, I suppose, seed investment from the Irish Cancer Society, and then used that to leverage additional funding, which now is, I'll give you an example of some of the follow-on programs later on. So I thought it was important on Breast Cancer Awareness Day really to highlight some of the kind of key breakthroughs that have come from this program. And again, there's large numbers of breakthroughs, but I just picked out a few, which I thought were really kind of nice examples. I'll talk about the work from Professor Leonie Young on looking at, I suppose, why certain breast tumors, unfortunately, they may spread to different organs. And one of the common sites of spread is the brain. And can we understand what happens to the breast tumor to make that breast tumor go to the brain, and can we overcome that? I mentioned the work of Professor Bennett in terms of the impact of aspirin. And for example, she's done recent work on vitamin D, looking at the impact of taking those particular agents either pre-breast cancer diagnosis or post-breast cancer diagnosis in terms of outcome. I'll talk a bit about our work in trying to reduce unnecessary treatment for early stage breast cancer patients. And then I'll talk about a few studies on developing new treatment or candidate treatment options for triple negative breast cancer, and invasive lobular cancer, which is a relatively understudied subtype of breast cancer. So this is a really nice example of, bench to bedside research, which was fully within an Irish context. So this work was driven by Professor Brian Hennessy, a noted medical oncologist in Beaumont Hospital, the College of Surgeons, in collaboration with colleagues, Dr. Alex Eustace and Dr. Naomi Elster. And so again, what's seen in the context of HER2 positive disease, as I mentioned, you may get an initial response to drugs like Herceptin, but unfortunately, the patients may actually become resistant to the initial treatment. And one of the interesting things is we've kind of understood, based on basic research within the lab, why that happens. There's certain alternative pathways which are activated, and one of the alternative pathways is a pathway called a PI3 kinase. And that switch is turned on during resistance. And what essentially this work has shown is, well, we can actually use a drug to actually hit that second switch. So if you combine drugs against PI3 kinase with HER2 target therapies, you can come up with a novel way of overcoming that resistance. And what was interesting is that Professor Hennessy and colleagues actually initiated a kind of groundbreaking, first of its kind trial in Ireland, in anywhere in the world, testing this new drug, copanlisib, which is this PI3 kinase inhibitor. And again, they reported very recently the phase 1b clinical trial studies, and I think there's phase 2 studies which are ongoing. I mentioned Professor Leonie Young and Damir Barrier-Leva, and they carried out some very interesting work in the context of this transition. For example, we know that in between 15 to 30% of women with advanced breast cancer, unfortunately, the tumor will spread to the brain and obviously have significant effects on the patient. And what these investigators did is they actually took samples from the same patient, but the primary breast tumor and tissue from the tumor when it was actually had gone to the brain, which was obviously very challenging to get. And what they found in about 1 in 5 of those cases, there was a switch from HER2 negative, where you don't express the HER2 receptor, to HER2 positive. So when the tumor goes to the brain, it seems to become HER2 positive. And then obviously, if that's the case, maybe this might provide an opportunity to target the HER2 positive disease in the brain. I mentioned again that triple negative breast cancer is, there's a huge interest in trying to come up with new therapeutic options for this disease where there's classically hasn't been targeted therapies. And again, some key work from Professor Joe Duffy and Professor John Crown with a PhD student, a very, very talented PhD student at the time, Dr. Nisha Sinnott, was looking at a particular target called P53. And P53 was one of the most commonly mutated genes in triple negative breast cancer. About 80% of triple negative breast cancers have a defect in this gene. And they looked at the activity of a novel drug, which could actually kind of change that modified version of P53, this gene that's mutated, into like a correct or good form. And they actually showed a combination of this particular drug, APR-246, in combination with classical chemotherapy. And this led to significant impact. And there's a variety of different ongoing clinical trials now actually testing the impact of agents which target P53 in the context of triple negative breast cancer. And again, Nisha's work was profiled on a specific, in a number of different venues. Work from our lab in collaboration with Professor Darren O'Connor, who's based in the College of Surgeons. Again, a very talented PhD student from my lab, Dr. Bo Lee, published a key paper in the journal Cancer Research. And Bo's work actually identified a novel protein called CDK7, which is present at very high levels in triple negative breast cancer cells. And we found that in tumor specimens or patients which had high levels of CDK7 in their tumor, they were more likely to experience a disease relapse after chemotherapy. And what Bo's work showed is that you could actually use a drug against this specific protein called CDK7, and you could actually halt the growth and kill essentially cells, triple negative breast cancer cells. Now, again, what's happening interestingly in this space is that there's a variety of different companies which have developed drugs against CDK7 in the US, and actually there's an Irish/UK company called Carrick Therapeutics, which has a drug in that space. And they've recently completed phase 1/2 clinical trials in both triple negative breast cancer and the ER positive breast cancer. So maybe this could be an attractive therapeutic target down the line. And kind of other work in ER positive breast cancer. And again, as I mentioned, the vast majority of patients with breast cancer present with estrogen receptor positive disease. The challenge is that while hormone therapy is particularly effective, in a subset of patients, unfortunately, the endocrine treatment fails. Patients become resistant to hormone therapy. And really, you need to understand why that's the case. And key work from Lisa Dwan, who's a PhD student whose mother was affected by breast cancer. She published a key paper in Cancer Research recently, identifying a protein called USP11, which was essential for function of the estrogen receptor and could be a new target for treatment in that context. Lisa was exceptionally talented, and now she's a postdoc in Cambridge, and she received a number of different awards for her work. So I'm shifting to the last couple of examples here. So again, as I mentioned, invasive lobular breast cancer is a relatively understudied subtype of breast cancer. And I'd like to give a shout out to Siobhan Freeney, who's a patient advocate we've worked very closely with over many years. And she's a strong advocate in the context of lobular cancer. It accounts for about 10 to 15% of newly diagnosed breast cancers. It's difficult to diagnose. It presents challenges in terms of mammographic screening. In a large majority of cases, the patients are chemo-resistant, and patients unfortunately have a poor outcome if unresponsive to anti-endocrine treatment. And what work in collaboration again with Professor O'Connor and Trina Niconile, led by another PhD student, Dr. Louise Walsh, identified a key protein called BRD3, which again, high levels of this protein correlated with worse outcome in invasive lobular carcinoma patients. And again, what was interesting was there's a variety of different drugs now which are developed to target these types of proteins, and work ongoing again in collaboration currently with Dr. O'Connor in my lab. We're looking at really trying to bring this forward closer to now, just one step before the clinical trials. We need to do further clinical models testing this therapeutic approach. So this last story, this is one that's been working on for many years. And again, this is this area of in the same space as Oncotype DX. And again, Oncotype DX is a very useful assay. It's offered for public and private patients in Ireland of a specific type in terms of early stage hormone receptor positive patients. And the key question again here is, can we identify patients who are at very low risk of distant recurrence and may safely avoid chemotherapy? Again, it's the vast majority of patients in that context. So the nuts and bolts of it is I had a very nice collaboration with Dr. Adrian Bracken in Trinity College Dublin. And the main person who was leading this work was a former centre coordinator for Breast Predict, Dr. Fiona Lanigan. And we developed essentially a new test called OncoMaster from many years of work, which could actually, it's a more effective predictor of patients which can actually safely forego chemotherapy. And we showed that improved performance of this test in side-by-side comparisons versus Oncotype DX in various different papers which have been published over the last number of years in over close to 2,500 patients from a variety of different countries around Europe. So this test is now CE marked. It's now being progressed by another company in the US, and hopefully will be available clinically in the next year or two. So I mentioned Siobhan Freeney, and again, I think it's very important to indicate that I suppose we've been on this journey as cancer researchers in terms of effective working and engagement with patients in an equal kind of partnership approach. Again, work from a very close colleague of mine, Professor Amanda McCann in UCD, had driven forward a patient voice in cancer research. But it's important to indicate that we've, I suppose, as Breast Predict researchers, we've been involved in a variety of different interactive events and activities with patients throughout the course of our work, and it's a very important aspect. So in the last 5 minutes, if that's okay, Rob, I'm just going to kind of talk about, I suppose, the next steps of where we're going forward. So I suppose Breast Predict finished, and it had, again, as I mentioned, it was a very, and the legacy will happen many years afterwards in terms of new treatments, new diagnostics. But again, it was important that we had some kind of succession plan in terms of activities. And we were delighted at the same time as the program was ending to have a new program start called Precision Oncology Ireland, which includes a significant aspect of breast cancer research, but also covers other tumor types. And as Rob indicated, This is unprecedented in the sense that we have 6 cancer charities, including the Irish Cancer Society, involved. There's a very ambitious research program, again, in this area of precision medicine, more targeted treatment options. Also, we have significant company involvement. And again, a lot of the people who are involved in Breast Predict are involved in Precision Oncology Ireland. Again, fundamentally, we're asking similar questions. Can we subsegregate patients, 100 patients of a complex mixture into subgroups where we can give more effective treatment options? And really what we're trying to do is leverage the power of computational approaches where we combine different data from the tumor specimen with clinical data from the patient, with imaging data. Can we come up with sophisticated models, also using the new science of artificial intelligence to come up with better diagnostics and treatments? And our work activities are span both diagnostics, developing new drugs, and also sharing of resources. And one of the resources that we are running is a tissue imaging platform. This is specifically supported by the Irish Cancer Society. And essentially the nuts and bolts of it is we're providing a dedicated research pathologist, who's indicated here, Dr. Claudia Ora, who's providing specialist input in terms of biomarker studies. Also a PhD student, Arif, who is actually specifically working on developing new tests to look at immune cells in breast cancer tissues and come up with, I suppose, more sophisticated ways of predicting patient outcome. And again, another key person there is Dr. Arman Rahman, who's kind of coordinating the whole activity within that group. So again, I'd really like to acknowledge the continued support of the Irish Cancer Society, but also, again, the people on the ground who support the Irish Cancer Society. Without that support, we can't continue our work. So in the last couple of minutes, I want to just tell you a bit about, another passion of mine. And throughout my entire career, I suppose this has been my holy grail, is really to bring everybody across the entire island of Ireland under the broad banner of cancer research, really to integrate cancer research or provide a framework for cancer research across the entire island, from both basic translation and clinical research across all aspects. And so this is really what I've been working on over the last year, and I'm continuing to work with many, many different colleagues across the island. And this is called ACRI, the All Island Cancer Research Institute. So what we're trying to create is a cross-border program connecting researchers both north and south and east-west to reduce fragmentation in terms of what we're doing, build critical mass of researchers in specific areas. And this is not like a bricks and mortar program. This is connecting people on the ground. I'm just going to finish on this video. It's narrated by Aidan Gillen, who's also, I suppose, you've seen on the program Kin, but he kindly did a narration for this 1.5-minute video, but to give you a flavor of ACRI, and then I'll finish off on one slide.
On the island of Ireland, 1 in 2 people on average will develop cancer during their lifetime. People's lives change overnight. A cancer diagnosis brings huge worry and anxiety not only to patients, but to their families also. We want to help patients live longer and better lives after their diagnosis. We will connect cancer researchers across the island of Ireland. We will work alongside patients to make sure that their voice is heard. By coming together, we can harness all of our different skills and expertise to better understand cancer, to develop more personalized treatment options, to ease suffering and save lives. This is our vision for the All Island Cancer Research Institute. We will work hard to uncover better diagnostics and treatments for patients. We will learn more about preventing cancer, as well as tackling key issues related to living with and beyond it. We will become a global leader in cancer research, and as a result, we will give much needed hope to patients and their families. Please join us in our mission.
So again, I suppose the kind of the bottom line, the key focus of the ACRI mission covers 4 kind of key aspects. We want to come up with strategies for improved cancer prevention, early diagnosis. We want to develop approaches which have less treatment toxicity, but also we want to have an activity in a very important area of survivorship, quality of life. So again, this particular program will again cover multiple different cancer types. but also, have a major focus on breast cancer. So again, anybody who's interested in helping us drive forward this program, please feel free to contact me. And again, I'm just going to finish off by saying thanks very much again to the Irish Cancer Society for their support. You've been fantastic to deal with. I consider you very close colleagues. And also, I would like to give a specific word to my wife, who unfortunately was diagnosed with early stage breast cancer about 2.5 months ago. And she's battling through it, but it shows you that, particularly, I suppose, cancer researchers are not immune to cancer. That's how I always say. Take care.
Thanks very much, Liam, and we wish Catherine and the rest of you all in the family the very best as Catherine goes through her journey there. Thanks, fascinating oversight, and I hope people will be impressed by the volume of work, and I suppose by the role of the researchers that they're supporting in our community to be able to undertake this work. We have a large number of questions, and it's really supportive to see. And I think I suppose the caveat of that neither Liam nor I are clinicians, so we don't treat cancer. We can't prescribe and write prescriptions and that. So some of the elements I don't think we're going to be able to deal with in the depth that people might like, but we'll do our best. So we'll fly through these in the order that they came in. We'll do our best. Some of them may need me to answer. Some of them are more specifically for Liam and that. So the first one is from Siobhan. Could you talk about the other unknown factors that lead to breast cancer, i.e. non-lifestyle, non-genetic, and research therein? I think it's important to say, maybe Liam, at the outset, that I suppose everybody, I think you hinted at that as well, everybody has a risk of developing cancer, and anybody that has a breast has a risk of that. So I guess I'm always a little bit uncomfortable with things being the cause and that, because I think we're talking about things increasing and decreasing the risk. And I suppose when I see that, when we talk about non-lifestyle, non-genetic, I suppose I'm always conscious of that kind of spontaneous aspect in it. So have you any thoughts on that, Liam?
Yeah, no, I agree with you, Rob, because, this kind of blame issue that people kind of look, was there something I did that caused the cancer? And I don't believe in that at all. Again, you can't blame yourself for getting older, and ultimately people have just different susceptibilities. Again, it's the question is a tough one because it's non-lifestyle, non-genetic. We think a lot of it is lifestyle related, and a lot of it is genetic. Essentially, you may have inherited alterations as a small percentage of patients which have inherited forms of breast cancer, which give a high risk of getting. It doesn't mean you're 100% going to get breast cancer, but it could be 50 to 70% chance lifetime risk of getting breast cancer. We know those genes, the kind of low-hanging fruit that it's called, but there are certain genes which are kind of give maybe a modest increased risk of breast cancer, and we're only starting to really understand those. And the difficulty is that could give like a 2 or 3-fold increased risk of breast cancer. What do you do about that? You know what I mean?
Yeah. And I suppose we maybe try and bring that one, because we've 8 or 9 questions, I think. We'll get as many as we can. I guess to bring that to a conclusion, I suppose there are things that can increase the risk. It's not that they're causes or whatever. And we know that things like, for example, women who give birth younger tend to be associated with the lower chance of having breast cancer. Women who breastfeed, for example, they have lower chances of breast. But these are often quite small, subtle effects. Conversely, we know that women and people who take in large amounts of calories in their diet, for example, have an increased risk. So, so the next one is more a kind of a medical one. I was diagnosed with invasive ductal carcinoma 2 years ago, had a mastectomy, chemo, and radiotherapy. How do I know if it's growing back? Again, are we not allowed PET scans? I might take that one, Liam, just to be quick. I guess the challenge is PET scans pick up about 7 to 8 in 10 cancers, often larger cancers, by the way that they work. So they are not a cast iron method of picking up, and especially not great at picking up early stage. I guess there's a limited resource in those, and they have their own consequences. The actual test has its own consequence. So it's a balance for a clinician. And I would suggest maybe have a chat with your clinician, and especially your oncology specialist nurse, your liaison nurse about, concerns about growing back. I think those are really common. And I often, it's those methods, been sensitive to ongoing changes in one's body that can really kind of pick those things up. The next one from Virat, what kind of diets are responsible for breast carcinoma, and what ranges of obesity are more prone for breast cancer? It's one I think the two of us can kind of deal with. And again, I think both Liam and I are uncomfortable with this kind of cause thing, so responsible for breast carcinoma. So I think we have to state again that breast cancer arises and has the risk of arising in everybody, and there are things that one can do to modify that risk. And I suppose there's a lot of nonsense spoken about diets in terms of preventing breast cancer, and that I suppose what we know are the general things that high calorie diets tend to increase the risk of breast and a number of cancers. Large amounts of alcohol in the diet, or taking that again, is a risk. And conversely, people who exercise regularly and who eat a diet that's rich in plants and that tend to have low risk. Liam, I don't know if you wanted to.
Yeah, I just want to make just a general comment. Maybe not directly answering it, but I suppose the whole obesity kind of cancer link is we're learning a lot about that. That's the kind of key unanswered, and that's the area that we're hoping to explore within ACRI. There's some very good research taking place with Lydia Lynch in Trinity College Dublin, looking at, I suppose, the effect of obesity on immune cell biology and how that may affect therapy. We're just trying, and also the work of Carl LaRue in UCD, not so much in the cancer space, but looking at, I suppose, the connection between the gut and the brain. And really, this idea of, fat shaming is just not, it's just a no-no, you know what I mean? You've got this concept of the terminology that people use and how it's represented in the media. And I think the broader context, we know that there is a connection between obesity. There's a kind of biological communication between obesity and cancer, and we're trying to disentangle that. What's interesting is there is some work out there potentially, not specifically in breast cancer, the work of Donald Brennan and others, where they're considering, in certain cases, the use of, say, bariatric surgery for the treatment of certain cancer types, for example, endometrial cancer. So there's interesting work. It's hard to disentangle it, particularly.
Yeah, I think we're still kind of early stage, and I think the most important thing is not to bring the guilt and those things in. So I agree with you on that. One from S Lane, which I assume is Sarah. There's a lot of media attention on menopause and HRT at the minute. What's the latest on HRT and breast cancer risk? I might take that one. And I think, I suppose early studies indicated that there were risks, and that actually caused significant health problems for women overall, because a large number of women then turned away from HRT. And this is one where we would advise people to talk to their GP and I suppose work out the risks from their perspective. The latest research is that the risks may have been overstated in the earlier research. It does appear that the duration and the time at which somebody starts HRT can have a relevance, and that I suppose HRT is a double-edged sword. So for certain types of it, and not all HRTs have the same risk, and there are different types of HRT. For certain types, the risks are low, if not negligible. For others, there may be a small increased risk, but HRT may also reduce the chances of stroke and heart attack and protect bone health and stuff. So it's a complex interplay, and I think really that needs a one-to-one conversation with a GP who understands the woman's health and the wider family situation, etc. It's not a straightforward one to kind of do. Next one, I listened to a webinar last year on a breast cancer study by Prof Kelly, presumably Kathy Kelly. There was a mention of a clinical trial using palbociclib in early hormone-positive breast cancer. Are there any results of this trial, Lynn? I think there were patients registered on it, Irish patients registered.
I can't remember the exact name of the trial, but again, I suppose it's important to note that there's, I think, at least 3 different cyclin-dependent kinase inhibitors. They're not all exactly the same. There seems to be some differences. I think the initial trial that you mentioned, I think, was what was called a negative trial. It wasn't as specific. It was expected to have a more positive result, but it wasn't as positive as they thought. And I think the other agents potentially, I think there are ongoing trials which may see a differential response, because again, these drugs were originally approved in the context of metastatic breast cancer, and the idea is commonly you start a metastatic and then bring it back earlier stage.
Yeah,
it was a bit of a surprise that it
so
wasn't.
I think that was an interim analysis. So the interim analysis, because I think to Rebecca's query, trials take a long time because obviously you need to wait and see the end result, and that takes many years, as Liam pointed out, particularly in breast cancer. That's actually a challenge now, because most women will live for a long period of time, and when really, you know, the outcome is to prevent death. So there definitely were Irish patients registered on that. My understanding, if I remember, and it could be wrong, apologies if I am, but as Liam said, that the interim analysis wasn't that there was a benefit in that wider population. That doesn't mean that some individuals mightn't get benefit. Next one from...
Can I just make a comment there? And this is
sure.
This is why biomarkers are important, because ultimately, you know, if we can identify upfront, one would guess there are patients who are going to preferentially respond in that subgroup in that trial, and that's the idea. Is there's ongoing research. Sometimes what might appear what's called a negative trial, where there's maybe not a difference across the board, you may be able to find subgroups of patients which have an enriched response, and this is very important, being able to go back to those clinical trial materials and people participate in research, because you can actually uncover new treatment options out of that. And that's for example how, you know, drugs like Herceptin were developed.
Okay, so next one, it's a specific one I think for you, from Amanda. Where is the current research on PALB2 gene and breast cancer?
I'm not 100% kind of aware of the data on that. Obviously, that's PALB2 is one of the genes, as I mentioned, which confers, when there's a mutation or alteration in that gene, confers an increased risk of breast cancer. I'm not sure if I think it's in the panels, which are normally, if you're sent for genetic screening, it's included in that panel. I'm not sure exactly, you know, in terms of the proportion of risk of breast and or ovarian cancer, but certainly it's an example of genes outside BRCA1 and BRCA2, which are predisposition genes that people have identified, and there's more. That's the thing, there are more genes. And
and they work together, and I suppose any of these genes are actually quite long, so there can be several hundred different mutations which can have different consequences. One that came in on the chat was, I suppose, a general one, and we can't really talk about the aspects from the clinical perspective there, the Catherine with recurrent lobular breast cancer. But I suppose the question is, how would you know if it's spread to the brain? How would you know it's spread to the brain? Again, Catherine, that's one I think you should have a conversation with your specialist oncology nurse. The common consequences can be myriad. There's a lot of different ones, but they can include, for example, weakness on one part of the body, you know, equivalent symptoms to kind of stroke and stuff like that. In very rare situations, there can be things like personality changes or headache or loss of function in a particular part of the body, but best discussed, I think, with your specialist nurse. We're banging through these now, so just give it another couple of minutes.
I think the next one is an easy one to address, an anonymous one, is triple negative breast cancer. It means triple assessment, negative or what? So what I mean by triple negative is that, again, when the tumor specimen is removed for testing, it's assessed by a pathologist and they stain it for 3 markers, ER, PR, and HER2. If you don't have any of these being expressed, it's called negative and triple negative. So that's what I mean in that context.
Sure. Thanks for the supportive comment there from Siobhan. Very much appreciated as always. I'm glad you're on the call, Siobhan. Good to see you. Question from Lisa: diarrhea and constipation, a possible side effect of Zoltec. Again, that's a clinical question, and I would always discuss side effects. And I think patients tend to underreport these, in particular to their nurses, because there can be side effects of treatment, but there can also be side effects from cancer itself. And these things really need a discussion. I suppose issues with the gut and bowel movements, etc., actually can become quite serious. So they do need a proper discussion with your healthcare team, if that's okay, Lisa. Pamela Sheehan, we're nearly done there. Diagnosed at 35. Want to see early detection of breast cancer, mammograms, more genetic screening. Do you know my sister waited 1.5 years for blood tests to detect a mutation, with doctors knowing I had the mutation? This is not right. Pamela, fully agree with you, and we've been working very hard on the Cancer Society. You're going to see a couple of things in that space imminently from us on that, but we fully agree with you. It is not acceptable that people wait when we have such great technology and know so much about the contributions. And I suppose what we're moving to is a more risk-based process of assessment and screening, and hopefully this will come within the next few years. We know that actually picking age is not a great determinant of someone's risk, that actually a combination of different things, including their hereditary risk, so whether sisters, mothers, aunts, etc., have cancer. So fully accept your point and would stand right behind it. And I think Liam would as well.
Yeah, I think the challenge has been there's obviously a shortage of consultant geneticists in Ireland. There's some very good ones outside Ireland, and I think there's been some recruited, but there's been a challenge in terms of in that space. It needs to be resourced properly. Very good people.
So I think we're all on the same thing. And I suppose related to that, another anonymous question there about the age of screening decreased. I would say not that it needs to be decreased. So breast cancer can occur at any stage, from teenage, unfortunately, right up to people in their 90s or centenarians. However, we know that some women are at increased risk of it happening at a younger age. And I think that's where we need to bring in the technology to help stratify people based on their risk. And Liam is really leading out on risk, I suppose, from a diagnostic perspective when people have disease, but there are people trying to work out as well the risk from an identification perspective. So in other words, in picking up the cancer. So I suppose the research indicates that an age-based, a simple, straightforward age-based, there isn't evidence to indicate that leads to saving more lives, which is what we all want to do. But there's quite a lot of evidence now that a better risk-based strategy is likely to give more benefit. Liam, I don't know if you want the last word.
Yeah, I just had a couple of comments. I suppose, again, I think currently in Ireland, it's 50 is the kind of dividing line. In some jurisdictions, they look at earlier. And again, one of the challenges, obviously, with the COVID pandemic, the breast cancer screening was paused for a while. It particularly had an acute impact on us because obviously my wife is 51 and a half. She went to her GP just to discuss hormone replacement therapy, and the GP is excellent GP, brilliant GP in Rathmines in Dublin, who said, "Oh, do you check her breasts?" And she detected a lump in her breast during that diagnosis. And again, symptomatic presentation, the vast majority is not found in the context of regular screening. It's patients finding a lump or their GPs finding a lump. It has a big impact. And if people weren't going to their GPs because of the COVID crisis, that potentially could have a knock-on impact. It certainly had an impact in our case because my wife wasn't called for breast check screening until a year after she should have been called. So, unfortunately, the disease was already there, but that could have been caught probably about a year earlier. So I think, if there's anything that comes from breast cancer awareness, regular breast checking obviously is, and how to do it, because again, it's assumed, I guess, that people do it and know how to do it, but, even it takes sometimes an experienced person to do it. So maybe be instructed by your GP how to do it, I guess.
Yeah, and I suppose I'd like to add to that as well, that we still have this concept of breast tumors being a lump. Quite a lot of them aren't, unfortunately, as well. So a lump will certainly pick up some of them, but some of them won't. And I think we should all try and get into this habit that if we notice something changed in our body, in any part of our body for a period of time, that might be a pain, it might be a discharge, it might be a rash, and it's going on for weeks, we really need to have a conversation with our GP. And I think that would help as well in these things. So we've spent an hour on this. We've tried to get through as many of our questions. Really very grateful. Liam is the same as me. We love getting questions and we always do our best to help answer them. So we've hopefully gotten through all of them there in a quick fire. Just to say thanks again to all of you for joining in today. I hope you found it interesting. You can follow the work on social media. You can see how progress is going. And just to finish off by saying on behalf of the support that we get from the public, we want to thank you and your team and your colleagues for all the work that you do to bring the latest advances and to bring hope, I suppose, to us all. So thanks very much for your time. A lot of work went into those slides and that presentation, and very grateful.
Yeah, and thanks very much for the invite, and best of luck, everybody.
Yep,
Take
best
care.
of luck. Bye now. Thank you.